Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Hello everyone, welcome back to the Pod of Inquiry. In this week's episode, I continue our discussion about neurocognitive disorders and the treatment of Alzheimer's disease by utilizing precision medical techniques such as genomics with Dr. Sandeep Kapoor. If you didn't get a chance to listen to last week's episode, I'd recommend maybe going back to that before you tune into this episode so that you get a little bit more of a foundation about what we're talking about. So without any further introduction, let's get into it. Dr. Sandeep Kapoor. Yeah, it's a big component in really a lot of health is, people have support, emotional support, people that they can talk to. I mean, it's very... So let's go look at the case study that you're going to share with us, because I think that's going to bring in a lot of the fine little nuances and kind of cement what we've already talked about.
So, I'll try to make this more interactive in terms of just, we've talked about some of this, but this is just one of my cases. He's a patient that currently exists, and he's doing really well still. He's someone that's been treated now as a long-term case of my patient who, was a 79-year-old gentleman. He is, he's now probably 81
Wow.
Now. It's a couple of years ago. But he had some short-term memory loss and really came to me and was essentially saying, he had troubles cooking. He had some issues with his, short-term memory, and his partner was also noticing it the last 10 months. I had some of the genomics done through Medicare, actually. I knew he was a 3-4, but I also know, because I'm a family type doc, so I took care of his mom, who died in her early 90s, and she had a lot of vascular issues, right? So she had peripheral vascular disease, something that you probably help us with, or with in lower extremities, and very bad vascular disease, and had some sugar issues, and but she had vascular dementia that I did not know at the time. This is probably about 15 years ago, what to do with her. She died in her 90s. But so this gentleman, had some signs again and he really demonstrated that he had mild cognitive impairment, scoring a 23 out of 30. So there was definitely some issues going on. He was definitely someone who had that issue. And he was on, because he had the MTHFR, the genotype, so that he was one copy of that. So we did have him on some B12, et cetera. We had him on some vitamin D and some basic things that I do for all my patients. But, when doing the, he had some ADL issues. This is just talking about his social situations. And we talked about that, being embarrassed in front of his socially. So these are signs and that are happening that are subtle maybe for some people, but he was an avid cook, and he forgot his recipes. And that's a key factor of things that because following a recipe, I guess, in cooking is very complex. I don't like to cook, and I'm not a very good cook. But it's pretty complex, and timing and all that stuff. So maybe that's why I ruin most recipes, but he had some problems with that. So when we did his full genomic patterns, we really started to see that he had the ApoE4. He also had some clotting factors, so that's goes along with perfusion. So that was the platelet aggregation factors, elevated Lp(a). This is a blood test that you can see too. There's some of the genes will be able to be actually blood tested. But genomics gets at the things that you can't really assume from blood testing, like what's happening in the brain or what's happening below the surface from a blood test, right? So blood test, this gives it much more precision. So he did have the MTHFR IL-6 combination that increases his risk fourfold for vascular disease, vascular dementia. And this one involves diabetes or mitochondrial issues. And then he also had some significant issues with detoxification and in not even having some of the genes that actually help to detox. He had some deletions in those.
Real quick, Sandy, what was his homocysteine? Did that correlate with the MTHFR?
Yes, his homocysteine was probably around, well, since he was on some B12, it was maybe about 11, which it really needs to be close to 7 to really optimize it. And so you have to use B complex, you have to use and add what you need to be able to, in precise dosing. So the tool, the genomic tool will give you that roadmap for what you precisely need to. So I got more precise with his and got his homocysteine down.
Okay. I just always have seen that there seems to be a high correlation between, the methylation and elevated homocysteine. And I was just wondering what your...
Yes, yeah, that is there. I use that, and that's what we had to go with before genomics.
Right.
Looking at red blood cell folic acid and looking at B12 and methylmalonic acid, those kinds of things to really establish what your homocysteine pattern is. But it is one part of the puzzle. So, but certainly, and as part of what the Bredesen protocol tells us through the studies, is that we need to have it as close to 7 as we can, optimizing cardiovascular health and stroke health along the way with that. So,
did this patient have any history of coronary artery disease?
Yes, he did.
Yeah. Okay.
He did. He had, but again, the thing about coronary, everybody at this age is going to have coronary artery disease, right? You're 75, right. You're 79, you're going to have coronary artery disease in some their fashion. That's why I will look at the cardiovascular genes and SNPs to make interventions. And so keeping in mind, when you do change someone's lifestyle, when you go in and do all the things, like when you're looking at sugar and you have benefits all over the place, benefits in cardiovascular health, in metabolic health, in weight loss and that tire around your waist. All of these things are improvements. So we've taken people off blood pressure medications. Actually, this gentleman was on low dose blood pressure medications. And after doing the diet, we didn't need him. So we didn't need the blood pressure medications. And also the risk of over controlling blood pressure, which is also going to be a perfusion issue. So if you overcorrect, we tend to believe, yes, undercorrection of hypertension leads to brain dysfunction and kidney dysfunction, et cetera. But when we get to a certain age too, we've got to make sure that we are not under perfusing by overdoing it with the blood pressure medicines that we give. Because oftentimes patients at this age have seen a cardiologist, they're on cholesterol medicine, they're on diabetes medicines, oftentimes, and they're also on blood pressure medicines. And we really need to see if they need it or not. Okay. So this is just a study showing that how do you figure out that the key is understanding when you have a patient sitting in front of you, how are you going to figure out what type of cognitive impairment there is? So when you look at studies, you start to say, well, lipoprotein A, which is really a vascular pro-clotting agent, is more associated with looking at patients who have vascular dementia versus Alzheimer's disease. And why is that important? Because we need to, we'll do some things to look at Alzheimer's because he has the ApoE4 and we'll correct all those things. But if we don't drive it home and we don't start looking at lipids and very focused on our perfusion, we're going to miss a treatment that's going to improve his cognition, which is what his mother had, but we didn't know it at the time. So she had a preponderance of vascular dementia. I think this gentleman has the risks for vascular dementia more so than he has a risk for classic Alzheimer's disease.
Mm-hmm.
So that's how those types of studies help us. And then, in the case of most people, this is just an example of the tool that is used and what we look at when we look at the gene. And this patient had one copy of this gene. And then it gives a clinician what can you do about, so should you take aspirin? Because aspirin will mitigate that lipoprotein little a. So should it be aspirin, or should it be another type of antiplatelet agent that's natural if there's risks for bleeding, et cetera? So that's where that unique way of actually looking at the patient and saying, well, the cardiac guidelines say that there is no benefit to giving a baby aspirin in an asymptomatic patient over the age of, I believe now they've lowered to 60 or 65. They've done studies. That's coming from the American Heart Association guidelines on what do you do for prevention of atherosclerotic disease.
Mm-hmm.
And so, but however, the consideration I used in this case, I used pycnogenol because that is an or nattokinase. Those are kinds of things that you can use in different in the place of aspirin. To me, aspirin has limited effects. I mean, it's an antiplatelet agent, but something like pycnogenol or nattokinase has vasodilatory action, increasing blood flow, anti-inflammatory effects on the endothelial lining. So it is highly, there's a lot more bang for the buck with that natural agent than there is aspirin. So, so there's where so for this gentleman, I didn't put him on aspirin, I put him on pycnogenol. Again, looking at ischemia or looking at cardiovascular disease, his other variant really looks at having this leaky blood-brain barrier. I mean, the brain has this unique protection factor called the blood-brain barrier. And we see in his case that this is, as a gene that could lead to a stroke, ischemic stroke, leaky blood-brain barrier. So these are things that, we wouldn't have known prior to that, and using different elements that have been studied, right? So in saffron, for example, is a great herb to use that actually will help you strengthen your blood-brain barrier. So this is where, they did a couple small studies that showed that, this using saffron is going to actually decrease amyloid in animal models. And they did a tiny small study with individuals that had outcomes equivalent to Aricept and Namenda, the two main medications that are approved for Alzheimer's. And it's like, wow, that's pretty powerful information about a natural molecule like saffron that gives the equivalency of donazepam or memetine, which, no one's going to be doing a clinical trial on saffron,
Can't patent it.
You can't patent it, can't figure out where to get it. It's, and so
go back to saffron 1 second, Sandy.
Sure.
Isn't it true that saffron also has a benefit from basically mood? It's been shown to be a mood elevator.
Yes, so actually they did a study with 30 milligrams of saffron in I believe it was a 6-week trial or 8 weeks, or there was a mood improvement. So it's also got other factors. I think I love saffron. I think it should be in everything. There are so there's more and more research coming out, about the mental health aspects. I mean, it cannot be ignored in terms of even with cognition and so when we're looking at depression, I mean, it's one of those things that we want to rule out when we are approaching an Alzheimer's or cognitively declined patient. It's absolutely one of the screening tests. It's some of the things that we're using. But when you are losing, like even without being depressed, but if you're losing your memory and you're losing your ability to, it's depressing.
Oh yeah, for sure.
I mean, it is, and it's also because, people believe, and the culture and society is meant to believe, and we've seen it, it's not just believe, that it is a death sentence, really. It's like, well, you have nothing you can do. There's nothing, it's written in your genes. And if you've got that gene, you're going to go downhill. And that is not true.
Right.
So, but they end up feeling hopeless, depressed, dejected, and they'll understand that there are other things to do than just putting people on, antidepressants that don't necessarily address the issue. I'd rather improve someone's gut so that they can make more serotonin to increase their depression. I mean, to improve their depression, or to have more serotonin.
Right.
That is 90% of it made in the gut. So
right.
it just comes from a very different thinking. You got to come from a very different angle and think really differently. Other things that we used here is just acetylcholine, its effect on stroke. Acetylcholine is sort of that precursor to acetylcholine, which is the important memory neurotransmitter. And choline in general is that food for the nerve, or it's shortage, and people. So neuroprotection, choline bathes the nerves, and it's sort of a protective mechanism from them dying too. But a lot of evidence has been used, to show that it helps post-stroke and vascular dementia. This is another beautiful natural substance that has been really demonstrated in cognitive impairment as a benefit. And then we got to toxicity too. I mean, this gentleman, their toxicity is a big issue now. I mean, even looking at different substances and environment like mold and different infections, those are toxicities. Toxicities are not just environmental toxic agents. They also include bacteria and viruses that will invade the body, like COVID. And I know it affects people differently, but Epstein-Barr virus, all of these things become potential toxins.
Where's the most? I know you can get sulforaphane in some foods. What's a good source to get that from?
Well, broccoli extracts. I mean, broccoli, the stems of that is the most potent one, and it's you can eat a lot of broccoli, but the idea is that you're not going to get enough of the sulforaphane. And there's also myronase, which is oftentimes there's only one type that actually has it in it, that also will upregulate your anti-inflammatory pathways. NRF2 is one of the substances in the body that is super important in detox, inflammation, regeneration. And so the idea is, how do you harness those pathways? When everyone thinks about NAC, and NAC is a good thing for the liver, right? So liver detox, but it's a remarkable substance that will help your body to make glutathione itself, glutathione being the master antioxidant, the master detox agent of the body and brain. So so we used some of them to harness his detox pathways. Testing also to see if there are any presence of toxicities, mercury and other heavy metals. We do that screening too to see if the patient is experiencing any toxic agents, mold. Those are things that are coming up a lot more lately. And so we're working with, we're working on trying to figure out detoxification. If someone is truly toxic, and that's one of the factors that is part of what we believe is causing their cognitive decline, we are presented with a little bit more of a tough road to be able to address that and to be able to detoxify that patient.
Are you running these mold studies and heavy metals on everyone, or are you basing that off of their history of present illness and their past history?
Well, heavy metals I run on everyone that's going to be a brain patient because it's so common. So I will do that. But if I see also, there's a couple of other markers like MMP9, there's a couple of blood markers that are part of the panel that we do that suggest that there is oxidative stress or toxicity. I mean, I do a lot of Nutraval testing, which is basically looking at all of their elements of balance in their nutrition patterns. But essentially, I will do that. I will do mold testing. I'm doing more so because of the wet weather and people's leaky homes out here in California. So we've had a very wet winter in Los Angeles. So there's been a lot more mold. So you kind of have to do a really good history and figure out, are they living in a moldy home or so it is hard because some of these tests are sort of not covered, they're expensive, and then if people don't want to hear about mold, because then it's this whole remediation process and it can be tens of thousands of dollars. And so what we try to do is we gently want to start to identify those areas.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm excited to announce that we have a new sponsor for the show. Dr. Ed Glazer's Relax, Release, Relief Technique and Training is now a sponsor of the Pod of Inquiry. I call this technique the Triple R technique, and it's truly amazing. He has actually performed it on me. By asking your patient to point where it hurts and have them tell you what motion hurts them, you will know exactly how to position them. They will then lightly push against your very focused light pressure, so minimal pressure that they can barely feel anything. A few seconds later, you will feel a softening of their tissues under your fingers as the patient's skin separates from the deep fascia and suddenly slides. This is the release part of the technique called Relax, Release, Relief. It's a deep relaxation technique that reduces or eliminates almost all pain. 10 minutes after the release, most musculoskeletal pain is gone. The range of motion increases dramatically and permanently for most people. Muscle spasms, including trigger points, are gone. Duration of relief or recurrence is dependent upon the underlying cause of pain, which in most cases has already healed. It does all this by resetting the pain threshold. It's as easy as flipping a switch, and the results are astonishing. I know, I've had the experience myself. What I'm saying is you learn this technique and you'll be able to relieve a lot of musculoskeletal pain from surgeries, trauma, implants, and other diagnoses, including fibromyalgia and CRPS. Dr. Edward Glazer is the inventor of the Soul Support Mass Posture Orthotic and is teaching the lower and upper body in 2 weekend courses. I personally have experienced this treatment, as I've said, from Dr. Glazer, and it does relieve pain, and the technique is painless. Space is limited for these courses to 14 students in each class. Just go to rrrtv.net/course or tap the QR code on the screen to register. You'll want to really do this because it will empower you and give you a technique that really helps people and really will differentiate your practice from almost any other practice. Dr. Glazer's teaching 2 courses. Course 1 is feet to low back, and Course 2 is upper body. Now, the first course, Feet to Low Back, is being offered on October 4th and 5th and November 11th and 12th. And the upper body course is being offered on October 28th and 29th and November 18th and 19th. So go to rrrtv.net/course and get signed up for these today. Well, it's hard to have this kind of a load of toxins on top of all of the metabolic issues and to presume that that individual is going to function really well.
Yeah, and we try to pick things that will hit a number of patterns, that in terms of supplementation. So we can get, if we don't see like evidence of toxicity that is current, we still are going to want to drive help these pathways, because detox is a daily process. I mean, having a good bowel movement is the best way to really detox yourself every day. So I'm a big proponent of gut health and getting yourself clear, because that's the easiest way. So, vitamin C is kind of your easy, inexpensive way to help your bowels and also help your toxicity. So that's a little quick pearl.
I like that. Those are all healthy pearls. This is a little bit tangential, but I just, really became aware in the last several months about uric acid. And I did not realize that uric acid is actually an important antioxidant. And it's kind of like the body's version of vitamin C. I'd never really thought about that, because we always looked at it from a perspective of gout. It's like, oh, you got a high uric acid, 8.1 or whatever. We got to drive this thing down as low as we can go. And the answer is that might not be the right thing to do. You want to get it down maybe 5 to 6, but you don't want to get it below 5, right?
Right. So that's really important to understand. And that's really where genomics helped me with, because it does point out, it does have genes and SNPs that look at uric acid. And it's some of these studies will actually show that it's related to elevated uric acid is related to metabolism of sugar. And so it becomes like interesting to see that if you will actually decrease using a sugar medication called Actos even will decrease your risk of stroke in these patients that have these particular SNPs. So it's really fascinating to start to see that. And I agree that you can't, I mean, you want to look at a uric acid, even if they don't have a history of gout. And that's part of the screening that we do is look there. But you're right, we don't want to over control and have no uric acid, right? So there's a fine balance. That's that whole key of balance. Do I just knock it down and give somebody allopurinol just because I have because I want that number to be 3 or, instead of 6, 5 or 6? The answer is no. I will check the level. If it's 3 and you're on allopurinol, I'm questioning why you are on allopurinol and take you off it. I don't need your uric acid to be at 3. And I think also when you see, like, everybody associates it with gout. I don't have a red foot. I don't have a red, I never had that, so there's no possible way that I have an excess uric acid issue, and that is not true. I mean, it is a hereditary disease, and we do see that in the genomics, but we're seeing a lot more of it and also Dr. Perlmutter is a neurologist who did a lot of work in this area, and has got a great book called Drop Acid. But again, balance is key. Balance is key, not to overdo it or underdo it. This is just the slide that we talked about earlier, and just looking at this vascular dementia risk is what this gentleman had, because he had a copy of the MTHFR and a copy of the IL-6, and that gives you a 4-fold increase in vascular dementia. And it also gives you a 2.5 times the key here of Alzheimer's disease, but the key is really to understand that it's an independent factor, right? So it doesn't really involve having an ApoE4 gene. So this is one of those hidden areas that you come in as a 3-3. I have this combination, I'll be honest. That's I have this combination. I have a 3-3 as my ApoE status. But I have high cholesterol genetically, I have lipid issues, I have sugar issues. We all have something. And so now that I know that that's the case, I'm in my 50s, I'm going to be pushing hard on my vascular risk factors, but I'm correcting all of these things. I'm correcting my impairment in the MTHFR pathway. I'm controlling inflammation with resolvins, for example, and omega-3s for my IL-6. And we measure IL-6 in our screening tests. Sometimes we do more, but we measure that as a factor to look at in when someone comes with dementia. Curiously enough, I mean, IL-6 is elevated heavily in COVID. We did the COVID studies, and the IL-6 is an inflammatory marker. It's a very interesting one because in some places in some levels it can be protective and muscle training and helpful, but it's all about that modulation,
right,
of what it is. So again, here's just the treatment. We gave him some riboflavin, and these are also helping with inflammation. So that's where the broccoli sprouts have multiple positive effects across their green tea and some basic things, that are going to help lower inflammation in relation to brain inflammation. So that's the key too, is I look at things that are going to have multiple effects, right? So
right.
When there are holes in the ceiling, when a cognitive impairment patient has about 36, 39 holes in the ceiling, we're trying to plug as many of those leaky holes in the ceiling to give them back their cognition. And so sometimes you can, with precision and with knowledge, you can say, well, hey, geez, sulforaphane will hit like 4 of them, right? Mm-hmm. So picking, turmeric can do this, and berberine can also decrease inflammation, but it can also be very great for metabolism and lower your sugar, right? So, there are a lot of crossovers into that. So you don't look at genomics and genetics and say, well, I'm going to do every single supplement that's based on, that's not how it's read. In previous genomic panels, sort of the commercial ones that are really out there, they just sort of match up, here's what your supplement regimen should be. And that's not how genomics really needs to be looked at. It needs to be looked at as an individual tool that a clinician is going to be able to design an appropriate pattern to effectively do that. The great outcome with this gentleman was Daniel. In 7 months, his cognitive status went from 23 to 27.
That's big.
Which is a big jump in 7 months of following this protocol. And really looking at the lab data, he had inflammation markers decrease, cholesterol went down, he dropped his LDLs, his particle numbers improved. These are things that we look at in lipidology, and he was able to start to decrease his Lp(a). He also had hormone deficiencies in terms of testosterone replacement. So we did replace his hormonal needs, and that seemed also to be, well, precisely, it was shown that there are different genes. I mean, men need estrogen. And this is where I say, well, men have to embrace their female side, because they're like, well, why do I need estrogen? Right. Well, estrogen is neuroprotective. Estrogen is something that protects the brain. And there are certain genetics and SNPs that show me that independent of anything, with a man with low estrogen has a 3 times higher risk of Alzheimer's. There's combinations there, again, independent of that ApoE4. So that's where I tell them to embrace their feminine side. And the way to increase your estrogen is to give more testosterone. So that's where you can then have a conversion and convert more of your testosterone to the estrogen. So we follow those levels as well. So that's what we call the trophic or growth support needs, thyroid, testosterone. So all of those get optimized. So it's optimizing several elements. And that's how we get people better. We have to pivot and twist, but and sort of start to pivot. Use medications where it's necessary. This gentleman was very engaged and was able to not have to use any medications. Again, the idea of like whether to use cholesterol medicine or Lipitor or these things that are supposedly not good for the brain, or but there are, you have to individualize the patient. I didn't have to use cholesterol medication with this patient because mostly I could achieve it through diet.
Right. What are your thoughts on the cholesterol? Because the total cholesterol number is kind of a mythical beast from what I've read, that it doesn't really tell us a whole hell of a lot, except I interviewed Dan Goodnow, who I don't know if you know him or not. He's in Temecula, and
yes.
the guy's a genius. And
yep.
I mean, it's fascinating what he's done with plasmalogens and all. And his sweet spot for cholesterol is he wants it between 220 and 240. He wants a higher cholesterol for that membrane health of all of the cellular membranes, cell walls.
Yeah, so I think that, I think that, I have a lot of patients that will come to me and their cholesterol is 100. And right. I say, oh my God, you're not making testosterone. You're not making any lining or sheath to your walls of your arteries. So your membranes, and you don't have enough phospholipids. All of that is definitely there, and I have to take them off or their medication, and also just get them to eat fat. I mean, to eat good fats.
Right.
But the point is that everybody needs to be individualized. I always look at particle distribution. So my every single test that I do on cholesterol is at any age now is with these particles that are listed here, where you're breaking down and looking at the size of particles and looking at whether which ones are getting more likely to be in the wall of the artery. I'm looking at HDL and their functioning, and is there's HDL good? So I'm using that balance. But
what about oxidation, like oxidized LDL versus non-oxidized?
Absolutely. You got to look at oxidation and oxidative stress and the size of those LDL particles. You can see that just by lifestyle and diet, the small LDL particles are the ones that are more likely to get into the walls of the arteries, and we've lowered them. So we've got a more preponderance of those big balloon type LDL particles, which can be swept away nicely when they're used up. But I have sometimes I will use cholesterol cholesterol medication when I know that I don't have harm. I see I do have SNPs that look at statin intolerance and what it can do, and depletion of CoQ10. I mean, there are genes that will help me guide that pattern for younger patients or for patients too. But when it comes to cognition, I'm usually able to not have to use an agent because I'm shifting particles through lifestyle, and I'm shifting what they're eating. So having an ApoE4 alone is also not just clearing out amyloid, it is also clearing out LDL or cholesterol particles. So if you have a misshapen protein, as you do with the ApoE4, you can expect to see elevated cholesterol based on those having that ApoE4. So it's also a cardiovascular risk, and that's what it was originally touted as, when they started to look at apolipoprotein. So when you look at it, you have to look at it with you really have to look at it very closely and dive into like the patterns that you have with cholesterol before you just imagine that it's that it needs to be a lower rate. And yes, we have to get into fights with cardiologists sometimes and neurologists, everybody.
everybody's got their own narrative. You know, the cardiologist wants that cholesterol down to 160. Your brain guys want it at 220. Where the hell do you go?
Right, somewhere in between.
Yeah, yeah.
I mean, he was at 204 and 180. You know, if you need it, you need to have that. And even the having too low is not, you know, I have a patient who is on, you know, he's seeing a cardiologist, he's at high risk for, and I still can't get him to lower his Lipitor dose, despite giving him articles and all of that to the actual physician, but I'm still trying. I won't give up.
It's sometimes hard to break the old paradigms.
It is hard. And it's hard with patients that are older too. They still are stuck in that polypharmacy mode, right? When they've gotten old, you're old, you need to take these medications like the standard, the proton pump inhibitor, you know, the Nexium, the Prevacid, that's always there. We have a stomach problem here, take this.
Right. Which creates more problems down the line.
Right. Absorption issues.
Yeah. Nitric oxide.
Depletion. So, and this is what comes to me. I mean, this is those vitamins are a bunch of junk. I don't know what they are. And that's the thing. I mean, they've gotten a bad rap. You know, the idea is to try to re-educate people that, you know, if you were getting everything in food in your American diet, then we wouldn't need these, but you're not. And you're not, and nobody is. It's unless you're living on a farm, you're doing everything right. It's just not possible in our culture. So it's a re-education. It's a constant re-education of each individual. And that's why, again, trying to get the word out to people, patients, whatever we call them, clients, they need to demand more too of what the system's offering them, you know, when it comes to every part of care, whether it's, you know, but advocating, figuring out, and reading. I mean, I think a lot of people come to me, they've read Dr. Betterson's books, they've read about different ways to improve your cognitive function, and they're starting to see that. But it really is it's got to come from the consumer in that sense too, from the point of view. We will do our best as the practitioners and the clinicians to educate our colleagues on. And you know, we may hit walls, but you know, that's the idea of being a pioneer. You just keep going, and you keep trying to send them articles, to send them, and hopefully they'll have a chance to look at it. Or the best thing is to actually have a patient go back to see them or their cardiologist, and they just look at them and they're like, well, what did you do? Like, how come you look better, your skin's better, you're better, and you're not stuttering, your words are coming out clear.
Right.
You just look healthier.
Yeah, and I think that's sometimes the best way to re-educate other physicians is by allowing the patient to go back and show them the progress that they made.
The outcomes.
The outcomes really speak louder than anything. So what about, this is a little tangential, what are your thoughts on methylene blue? Because there's, you know, some compelling evidence that it being an electron donor, it can help. There's some stuff out of University of Texas, San Antonio, where they've been looking at methylene blue for cognitive issues, and even combining it with, I think it was 1040 nanometer lasers, different types of things.
So methylene blue is an interesting substance I've been using. I've had one patient that used it a long time ago. But I am actually very considering it, use of it after that lecture, after being at the ozone. So I don't know much about it other than the fact that it's sort of microdosed now, or, you know, and it's having some good data.
Right.
And I'm actually going to try it on a patient that is, you know, not doing a whole lot, not doing very well and is declining. And that same thing with low dose naltrexone, those kinds of new things. But yes, methylene blue is very promising. We need to do more with it. in trial format.
So what I was interested in with the methylene blue was that, the dosing, right? And it appears that the low dose, and again, like we talk about, everything has kind of a sweet spot. It seems to be, if you dose it 25 milligrams a day, something like that, it seems that the best way to tell when you need to dose it again is simply when their urine clears, because it's such a easy thing to see after you urinate. Okay, if the urine's still green, you're still good, so take it maybe every other day or whatever, every third day. It's a pretty easy drug to dose. It's interesting too that I believe methylene blue was the first drug ever approved by the FDA, and that was back in the 1800s. So it was pretty incredible. But there's been a lot of stuff. So interesting. Anything else on this patient study?
Oh, I think that sums up. He's doing great. He's doing well. See him often, though. We see him often to keep the maintenance going for him. Right.
Well, this is really illustrative of just being able to dive into him from a personalized standpoint, like your paper lays out, and address these different things. I think this is very, very powerful stuff. I'm just excited by what you're doing. I mean, I've had an interest in it for a long time, and I think there's so much on the horizon for people to, to live longer, normal, cognitive lives, and get out of this paradigm where, sorry, there's nothing you can be, done for it type of thing. So it's exciting stuff. And I'm proud to know you, because, what you're doing is really fantastic.
And I think, again, it takes an army, to meet at these conferences to be able to do this. I mean, it is about changing the trajectory of medicine and how it's done and how it's delivered. And that's really what we need to do. We need to be able to combine forces. I'm really interested in your work in terms of giving people their nerve flow back, with their blood flows, and being able to, I've told so many people about it. And it's fascinating to be able to think outside of the box. With your work with a neurosurgeon and on the arm. I mean, I still recite that story that, you're just in that right place, or with the right person that's mentoring you. And you learn so much, and you learn how to just, hey, what can we do with the leg? And, and how can we improve people's, and we've got to get you out here to see some of the patients to get them better. So,
well, I'd love to come out there and hang out with you for a few days. I think probably what I want to do, actually, I'll talk to you more after we get done, but I'd like to probably do this genomic testing myself and just see what we can do. Although I'm pretty much doing all of this right now as I'd probably be an easy patient for you.
Yeah. Well, we always find something. We always will find something to improve. That's the key.
So, Sandy, how do the listeners get a hold of you? How do they find you, the work that you're doing? If they want to plug somebody in or one of their family members, how do they find you?
So, I'm in the process of redoing a website and all of that. The easiest thing to do is Kapoor Medical is the name of my in Los Angeles. And my email is probably the easiest, for my nurse's email, who coordinates the programs, is elizabeth@kapoormed.com.
Okay.
And that's the best way, and really just calling to, we still do that, 818-392-5408. That is our portal. That's how we are doing it currently. We'll have more organized ways of being able to get that through our website. We do have a website that's currently up, but it doesn't have a lot of the other one is info@kapoormed.com.
I'll put this in the show notes so that they can link to that.
Perfect.
All right. Okay. Well, thank you so much for taking the time to, come on and educate us and share this with us. And I really appreciate your time, and thanks so much.
Thank you for having me.
All right. I'll talk to you soon.
Okay. Take care.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardioprotection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pot of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pot of Inquiry. Use Pot of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pot of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pot of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.